Hi, good afternoon everyone. I'm Dr. Lim Thien Thien. I'm the neurologist, consultant neurologist in Island Hospital, Penang, Malaysia. Over here today, with me is Dr. Hock Keong, our consultant neurosurgeon from Island Hospital. And briefly today, about 20 minutes, I'm going to talk about the myths and the truths and the facts about deep brain stimulation in Parkinson's disease. First and foremost, I'd like to thank Island Hospital to allow me to go live on Facebook. Not this one. This is Mr. Liu. This is not my slide. Okay. Alright, so before that, I'll just share with everyone. This was a video, a short clip that Island Hospital made many years ago, roughly around 2014 when we started deep brain stimulation in Island Hospital. So this clip actually shows how the procedure of deep brain stimulation is done, and without further ado, let's go. Deep brain stimulation is now a standard treatment for patients with advanced Parkinson's disease. Most patients can be managed initially with medication. However, over time, it becomes more difficult to manage these symptoms with medications alone. Deep brain stimulation then becomes an option. Deep brain stimulation is like a pacemaker to the brain. CT scan, which is done on that day where we fuse the scan together to get a good location of where the lead will be going into. So this is the fusion scan where we fuse the MRI and the CT scan to localize the area that the wire is going into.
There are many advances in the medical and the surgical treatments of movement disorder. DBS is a well-accepted surgical therapy of movement disorder like Parkinson's disease, essential tremors, and dystonia. It involves implantation of a small electrodes like the size of a spaghetti into a motor nucleus, deliver a small amount of electric stimulations, blocking off abnormal nerve signals that's giving rise to the abnormal motor symptom. The beauty of a DBS is adjustable and reversible. The stimulation can be adjusted to the patient's demands.
So as you can see over in the video clip just now, how DBS is performed in a patient. And many years ago, the master in movement disorder, David Marsden, used to say that he saw two miracles in his life, and the first was levodopa, a medication that creates dopamine in the brain where you take it orally, and the second was deep brain stimulation. It's a surgery. It's a functional stereotactic surgery where you insert a wire that you saw there and a battery and electrical currents where you actually help the patients reducing their symptoms of Parkinson's, including stiffness, the slowness, the tremors, and so on. So in this talk, I would like to make it more interactive since it's a Facebook live session and many people are online now. So what I'll do is I'm not just gonna talk all the time. I'm gonna give a statement, 8 statements in total, and what you can do by interacting is you can actually key in your thoughts on whether what I mentioned as the statement is true or is false. So you can just type into the comment section T for true or F for false. If you agree, then you put T. If you don't agree, then you put false, F. Okay, the first statement is deep brain stimulation, DBS, is a major brain surgery which involves opening up the skull. Is this the truth or the myth? Or is it true or is it false in your opinion? So I'll give a few seconds to the participants to actually answer and tell us what they think about this statement. So what did most of them say? Okay, great, wonderful. We have quite a number of responses. Most have said that it's a myth or it's false. So it's actually a myth that DBS is a major brain surgery which involves opening up the skull. So basically DBS is a surgery. It's an implant of a wire into the brain, and this wire later on will be connected to a battery, a small size battery just below the collarbone, which you saw in the clip just now. And this electric current will be sent into the brain, and it stimulates certain parts of the brain. So it's not a major brain surgery. The second statement, DBS, deep brain stimulation, is a cure to my Parkinson's disease. Would that be true or would that be a myth? So do you think that by doing DBS, it will totally solve Parkinson's disease? Okay, so we have a few mixed answers, 50-50 I would say. Some says it's true and some say it's a myth or it's false. Thank you for the responses. There are quite a number of responses, so I think now most of it is false. So unfortunately, up to date, there is no cure for Parkinson's disease. There's not even a medication or a procedure that slows down Parkinson's disease. So unfortunately, DBS is not a cure to Parkinson's disease. But however, saying that DBS actually significantly helps patients with Parkinson's disease, number one, it has been proven that DBS improves the quality of life of patients. So patients live much happier with DBS implanted, and it also helps the motor symptoms, whether it's slowness, it's stiffness, or if it's tremors or the shakings that the medications do not help, deep brain stimulation still helps. It does also help certain non-motor symptoms of Parkinson's, things like sleep and pain, that also Parkinson's disease helps. So it does help the patients in that way, but it does not cure the Parkinson's disease itself. The picture that you see on the screen now is actually the lead that is inserted into the brain, and it's actually magnified over here. And you can see that the yellow structure there is an area of the brain called the subthalamic nucleus. It's one of the nucleus of the brain where one targets in DBS. The GPI is another target that we use for Parkinson's disease, but most of the time we target the area called the STN, and that area is a very small area in the brain, about 1.8 centimeter, and the target is very important. And in fact, it is crucial that we insert the lead into the correct area of the brain to get the maximum effect with the least side effects. Alright, let's go on to the third statement here and tell me whether you think it's true or false. DBS is reserved for very late stage Parkinson's disease. Maybe when the patient is at the stage of bedridden, would that be a suitable candidate for DBS? So I'll wait for you all to key in your answers, and we'll see what the responses are. So there are some who answered both. There are some who answered depends on the age of the patient. About about 10 of you answered false. It may be early for younger patients. Thank you for the responses. Most of you answered false. Yes, the answer is actually it's false. DBS is not reserved for very late stage patients with Parkinson's disease. In fact, when the Parkinson's disease is late stage, when patients develop dementia, memory issues, the medications such as levodopa do not work anymore. Unfortunately, it's already too late to do the procedure, deep brain stimulation. We do not also do deep brain stimulation for very early patients, like the first few 1-2 years where they are actually functioning very well, medications work so well. We do not really offer DBS at that stage as well. So DBS is normally a good option when it's somewhere in the middle, I would say, meaning that when the patients start developing what we call as motor fluctuations. Motor fluctuations are when you take the medications, you can see a good effect in your symptoms of Parkinson's. You get less stiffness, you get less slowness, you get less tremor. But at one time, you'll find that your medication or levodopa does not last as long as you want it to be or it used to be. So in the first few years, you may find that you take levodopa maybe 2 times or 3 times in a day. And when years come by, maybe about 5 years down the line, 6 years down the line, you find that the medication doesn't last long anymore. It may last like maybe 3 hours, or maybe some of you last 2 hours. So it becomes shorter, and you find that you have to keep popping up levodopa pills every few hours, and it becomes a very hassle. And when you take the medication, sometimes you also develop what we call as dyskinesias, where you have these dance-like movements. It's those movements that you cannot control. So these dyskinesias are also bothersome, and it also disturbs the function of the patient. So at this stage, DBS is actually a very good indication. Patients will benefit from DBS when they have motor fluctuations or dyskinesia. So when you have what we call as the on-off fluctuations. Okay. The second reason why you would do deep brain stimulation is if you find that your medication, you have Parkinson's disease, but you find that your medications do not work well for tremors. Because not all patients who take levodopa the tremors will respond well. So what we call as refractory type of tremor. DBS still works in this case. So it's also another option. The third one would be when you have difficulty adjusting the medications, you increase the medications, you get abnormal, uncontrollable movements. You cut down the medications, you go very off, your symptoms come back. And it's not easy for the doctor who sees you to adjust the medication anymore. That's when the option of deep brain stimulation comes in. So these are the first few reasons why DBS would benefit. Or if you find that sometimes you are taking loads and loads of medication, you have levodopa taking about 6 times a day, you have your dopamine agonists, you have your other selegiline, all these medications coming in, and your symptoms are on and off problems still. So DBS would be a very good option, and the benefit of it, you being independent, meaning that you do not have to carry a pump or anything around. So that's another, those are the indications. But it's not reserved for those very late stage Parkinson's disease. So this is just a video that you just saw. So that's dyskinesia. You see those abnormal movements where you take too much of the levodopa, you develop these movements. But when you take not insufficient amounts, then you go off. Off meaning that you develop all the symptoms of Parkinson's disease. Okay, we go on to the next statement. With DBS, I no longer need to take any medication for my Parkinson's disease. Is it true or is this false? So do you still need to take medications after doing deep brain stimulation? So patients would normally be on levodopa, they would be on certain dopamine, what we call as dopamine agonists, whether it's pramipexole, ropinirole, rotigotine, or pyribidil. So would you still need to take all those medications after doing DBS? Right, great. So quite a number of responses here, and most of you said false. So yes, the answer is false. It's a myth. You still need to take medications after you have done DBS. So why do DBS? No, doing DBS does not take you away from your medications, but if we normally target the area like I mentioned just now, the SDN, you can actually reduce your medications. So generally about 30% of your medications are cut down, but there are some patients, I have patients who cut down up to 70% of their medications, but the function has improved, the motor symptoms have improved in the patient. So unfortunately, yes, you do still need to take your medications, and like I said, DBS is still not a cure, but it does help your motor symptoms a lot. The fifth one, DBS is a low-risk surgical procedure involving implantation of a wire into the brain. Is it true or is it false? So is it a truth or is it a myth? Okay, key in your answers. Right, so it's a little slow now, so it's an off time. Okay, all right, great. Now it's moving, and probably my line is lagging. So now most of the answers are true. Yes, so it's actually DBS is actually a low-risk surgical procedure. So it's not opening up the brain, like I said. So it's just an implantation of wire into the brain. So it's a very small wire that is going through the two small holes on your brain, on your skull. So, but yes, like with any other procedure, there are always risks involved, but the risk is generally low. I would quote a figure of less than 3%. So it can be bleeding in the brain. You could hit a blood vessel and it bleeds, but that chance, touch wood, it's only about 0 to 4.3% in case reports. Second, infection. So you could get infection in the battery, you could get infection in the lid, but most of the infections are superficial infections. They are not deep-seated into the brain. So there are centers whose infection rate is up to 25%, but generally it's between 2 to 25%. So it's not a high. Seizures can happen because you are poking something through the brain, but that is less than 3%. Misplaced leads, meaning the lead is in the wrong position, and that's why in our center here we normally do the procedure, the deep brain stimulation under special circumstances where we use micro electrode recording to make sure that the wire is inserted into the ideal place. It's actually another additional procedure where when the wire goes through, we know certain signals come out from the brain, and we actually used a machine to actually guide us to know which area of the brain we are going through. So we have an additional benefit by using this what we call as MER to know that our leads are correctly placed, and that's the reason why in our center I do go in for the procedure of DBS into the operating theatre, and that's the only procedure where I go into the operating theatre. I don't go into operating theatre for any other reasons. Okay, so yes, it is actually a low-risk surgical procedure. Okay, now we go on to the last three statements to see whether it's true or it's false about DBS. So the sixth statement is that DBS surgery is performed while you are awake. So are you awake or are you asleep during the surgery? Okay, you can key in your answers, whether it's true or it's false. So T for true and F for false. false, true, true, false, true, false, true, 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 true. Okay, wonderful. So majority would say true. Okay, true when they implant the electrodes. That's right, because when we do the battery part, you may be asleep. So yes, DBS surgery is performed while you are awake. So we do communicate with the patient, we do talk to the patients, and why is that so is that we want the patient to be awake, to be able to test the procedure at that time, so that we know that it's effective and there are no intended side effects, because the structure where we go in, surrounding the structure, there may be other structures that the current may actually hit. So then you'll get side effects like pulling, or you may get side effects like speech problems or slurring of the speech. You may get even mood issues, like you become very sad during when the implantation and the stimulation of that area of the brain. So we want to make sure that the lead is suitably placed and the stimulation around the area does not affect the other structures of the brain. And that's one of the major reasons why DBS surgery is done when the patient is awake, so we can actually test it out at that time. But of course, when we insert the battery, we'll make the patient sleep. Generally, it's not a painful procedure. It's just that the patient will be awake. Okay. The second last statement, DBS will help me in all my Parkinson's disease symptoms. So, as you know, Parkinson's symptoms are divided into two. The first would be the motor symptoms, where patients develop slowness, stiffness, tremor, instability. And you have the non-motor symptoms. Patients with Parkinson's disease tend to have constipation. They tend to have smell issues. They have anxiety, depression, sexual problems. They can have pain, sleep issues, whether they wake up and sleep at night, urinary problems. So these are all non-motor symptoms of Parkinson's. So the statement here is that DBS will help all of my symptoms. Is it true or is it false? Taste issue, more of smell issue. Someone was asking about taste issue. It's more of a smell, what we call as anosmia. Just be careful, COVID also causes anosmia, but this is normally a chronic anosmia. You may not be able to smell well for maybe the last 10 years or so before even developing the symptoms of the tremors or the stiffness or the slowness. Okay, great. So majority of you go for false. Yes, olfactory, that's right. I was looking at OLDFACTORY. It's OLFACTORI. Okay, right. So remember that if you decide to do deep brain stimulation for your Parkinson's, decide carefully on what you want to achieve before deciding on doing DBS. So if a patient comes to me and tell me that I want to do DBS, I'm keen for surgery, and I ask him or her, why do you want to do DBS for yourself? And if the answer is that because I'm having constipation, and constipation is part and parcel of my Parkinson's disease, I say please don't do DBS, because that's not gonna help you in your constipation. Or if let's say the patient has some bad swallowing issues, yeah, I wouldn't recommend DBS for those symptoms. So the symptoms that would be responsive to DBS would be stiffness, slowness, tremors. So these three symptoms are quite responsive to DBS. Dyskinesias, where you take the medications levodopa and you develop those dance-like movements, yeah, that will be responsive to DBS. Wearing off the medication doesn't last as long as what it should be. It lasts for maybe 2 hours, 3 hours, and you want it to be longer, so that DBS will be helpful in those cases. Certain cases, pain from Parkinson's disease, of course not pain from something else, sleep issues, yeah, but it should be a combination of the motor symptoms as well to benefit from DBS. The unresponsive symptoms, unfortunately, speech, and in fact sometimes speech may become more problematic after DBS, swallowing issues. If you have memory issues from your Parkinson's, you go into stages of dementia. In fact, that's poor, and we normally do not offer DBS anymore if you have dementia, because DBS itself can actually affect the memory as well. Gait issues like walking, only if the gait issues means like the walking, they have difficulty in walking, and they take the levodopa and they find that the walking improve, DBS does help in those cases. But if they take the medication and the levodopa, the medication doesn't help, DBS normally doesn't help in those cases as well. If you have depression, mood, behavior issues, although nowadays there are studies that are done to look at DBS in mood issues like depression, impulse control behavior, but generally we normally try to control the mood issues before doing deep brain stimulation. And like I said, constipation, they're normally unresponsive to DBS. The last one, DBS is an expensive surgery, and I'm sure everyone, most of you here would be asking, well, how much is DBS? It's such an expensive surgery, and do you think it's expensive? I know it's a very broad question to certain different people, but in general, do we consider DBS as an expensive surgery? You can put your answer as yes or no, or true or false. Oh, there's a capital letters TRUE in large. True. Okay. Okay. Right. Majority of you say that DBS is an expensive surgery, and I generally do not deny it, but I would say that it's something debatable. It's true and it's false as well. So roughly, DBS would cost maybe about 150 to 180K for the whole procedure. But if you look at it in a broader perspective, it does reduce disability and patient can work. So if let's say you do not do DBS and you take medicine and you find that you cannot work, so it would be a myth in the sense that you don't earn, but you and that's a negative income for you. So if DBS make you able to work and earn, it may be even a plus for you. And in that case, DBS doesn't become expensive if you put things in perspective. The third one is that DBS is covered by insurance as compared to long-term medications. And like I said, if you position the lead in the STN, you may be able to cut down medications maybe 30 up to 70%. And mind you that the medications for Parkinson's disease is not cheap. If you talk about things like dopamine agonists, the patch, rotigotine patch that we use, and we import it specially for our patients from outside of Malaysia. Those medications in 1 month, a patient may be spending 1,000 plus just for the medications for Parkinson's disease. So in that way, if you look at it in that way, you manage to cut down your medications, let's say 50% of the medications. It actually saves you in the long run as well. So you manage to reduce the cost of medication. So that's the other factor. You may be seeing people like me less if you have a DBS, in the sense that once you're stabilized, you don't need a frequent visit because you do not have very bad motor symptoms that you keep requiring to see your doctor or your neurologist. So I would say that would be a myth, because you'll be spending each time you see a doctor. Another statement is that of course, sometimes unless you develop DBS complications, yeah, it's gonna be even more expensive. But that generally is, like I said, less than 3% of the side effects or the complications of it. Another thing is that sometimes you think that, oh, DBS is so expensive, let's not do DBS, and then you develop such bad motor. I've got patients who develop very bad motor symptoms. They get dyskinesias and they fall. And they fall, they get fractures. They get fractures. So now it's not about DBS. You need a hip replacement. You need some screws. You need to stay in the hospital for a long period of time. So that in the end becomes more expensive. Or you fracture your spine. So that's more than 100K for that as well. So it becomes a myth that DBS is expensive because you spend more on something else that it could have prevented you. So I mean, we look at things in perspective. It can be true, it can be false, and yeah. So that was my last statement about DBS. So I'd just like to summarize all my 8 statements here, and the first one was that DBS is not a major brain surgery involving opening up the skull. It's a stereotactic functional neurosurgery where we implant 2 wires on each side of the, 1 wire on each side of the brain and connected to a small battery, and the current goes through into the brain. So that will help the symptoms of Parkinson's. Number 2, deep brain stimulation is not a cure to Parkinson's disease, but it does help the symptoms, and it does reduce the disability and also helps the function of the patient. And third one, DBS is not reserved for very late stage Parkinson's disease, remember. It's somewhere in the middle, normally after about 5 years after the onset of Parkinson's disease, and when you have motor fluctuations, where you have dyskinesias, and off period where the medication doesn't last as long as it does. But with DBS, you will still need to take your medications for Parkinson's disease. And the good thing about DBS is that DBS is a low-risk surgical procedure involving implantation of wire into the brain. It's not a big open surgery where you open up the skull and remove the brain or anything like that. And DBS is done when when you are awake, while you're awake, except for the last part of it. And DBS not helps all symptoms, but it helps the motor symptoms. It doesn't help things like speech normally, cognition, or gait that is not improved by levodopa, mood or behavior, which is actually debatable as well. DBS is expensive surgery. It's debatable, like I told you in my previous slide. So with that, with the summary, I hope that you got back some information about deep brain stimulation in Parkinson's disease. So before we go to a question and answer session, my colleague, my neurosurgeon, would give you a brief introduction and also tell you more about DBS from his perspective, the neurosurgeon's point of view. So with that, I thank you very much. All right.
Hi, good afternoon everyone. My name is Dr. Hock Keong. I'm a neurosurgeon and as a team member with Thien Thien for our deep brain stimulation for Parkinson's disease. I would like to thank one of our patients, Mr. Wong. He has a Parkinson's disease, and we have done deep brain stimulation for him. He's quite happy with it. I thought I would like to thank him because he's actually volunteered himself to give his testimonial to share with our audience.
我名叫王安安，我今年59岁，我这次回生已经10多年了。一开始的病状呢，我的手很僵硬，整个手僵硬，然后心情很不好，脾气很暴躁。做工的时候呢，专心做工都不能做什么。最严重的时候连驾车都不能驾，驾到一半的时候车要停车半路，要等那个恢复好了，然后才可以驾，车的驾才可以驾。我这里面的时候是2016年，做里面之后呢，我已经改善差不多有78%、88%，这是很好的症状。现在的生活情况呢，我没有什么幻想，只是 自己人自己顾自己，自己人吃饭，能走路，能驾车，能自由自在，还有养这个小狗，可以自己自力更生，不依靠别人。
Yeah, deep brain stimulations for Parkinson's disease, I would say, is one of the most rewarding surgery for neurosurgery because it actually restore the patient's functions, and on top of that is adjustable and also reversible. And this slide is actually showing the fibers, the circuits inside the brain. Our brain is like a supercomputer. It has many wires, many circuits, many IC inside there with different pathway interconnected. It's very complex. And Parkinson's disease is something happened in the motor circuits, whereby with the degenerations of the motor neurons, some neurons are firing abnormally and then causing symptoms of Parkinson's disease, as described by Dr. Lim, like for example tremor, rigidity, spasticity, or the instability. And this diagram is really showing that if you diagnose a Parkinson's disease at the early stage, if your disease is very mild, you actually respond very well to the levodopa, and you see the miracles. You have many on time, very long on times, very short off times. But with time, when the disease progress, then your quality times become less, your on time become less, and then sometimes with the medications you develop some abnormal movements like dancing movements. We call it a dyskinesia. Deep brain stimulation is able to maintain patients with more on time and less off time and remove the dyskinesia. And this is just a diagram showing that how we put leads into the motor nucleus, and then we connect the wire down behind the ear and then below the collarbones, and we place the battery. And I can show you the model here. This is the hole that we're going to make. A small hole is about 12 millimeter hole, both sides at the front here. And then this is the lead that we're going to put in. It's very fine wire. It's about 1.2 millimeter lead, and then the battery is also very small. It's about 2 inch in size, and also it's very light. That's the next thing we would like to share about the surgical procedure in our hospital. Overall, Thien Thien and me, we have performed about 17 patients for deep brain stimulations, and we are quite standard in our procedures. So usually patients will admit 1 day before operations. We'll off the medications, and then we'll do an assessment. And the following days, then we'll do a surgery. The procedure takes about 5 to 10 hours, and most of it is done under local anesthesia, as said by Dr. Lim just now. And after placing the leads into the target area, which is a subthalamic nucleus, then we will put the patient into a sleep, and then we will put the battery just below the collarbones. And subsequently, the patient will send back to the wards for 2-3 days, and then we only start the programming after about 2 to 4 weeks, usually 1 month after the procedures. And this is the diagrams of one of our patients that we put the special frames early morning under local anesthesia. Patient is still awake, and then we send out for the CT scan brain. And this is the machine we use for to target the motor nucleus. And again, this is showing the red nucleus, and the red dot here, although it's very small, this is the area that we are targeting. based on the MRI. Again, this is picture showing that these two red targets. This is the red nucleus, and then the target is over here at the side of this round red nucleus. And before we really start anything, making hole, poking in the wire, we will do the trial first.
Start.
And then you can see that from the computer showing us where is our trajectory. Is it safe? Is it hitting any abnormal vessels or enter into some abnormal area or not? And this is a diagram showing that we clean the patient head properly, placing the frame, and we assemble these complicated micro drives, which is one of the instruments to help us to place the electrode. And this is a very fine electrode. We use it for the micro electrode recording. That means the motor nucleus is in a different area. They produce different sounds, the activity sounds. So from this, this gives us a valuable information whether we have reached a subthalamic nucleus or not. Because subthalamic nucleus has a very distinct and very different motor activities. And based on this will enhance and improve our targeting process. So far, out of our 17 cases, we have 100% accuracy hitting on the targets. And we do post-op CT scan to assess the locations of the lead for every patient. And this is the activity, and we're able to detect when we reach a red nucleus. Reach a subthalamic nucleus. And this is a diagram showing that the instrument is used to fix the lid, to secure a lid over the hole on the skull. And after we successfully placing the lids, and then we'll remove the frame, then we'll put the patient into a sleep, and we'll start the process of implanting, tunneling the lid down, and then we'll put the nucleus, the batteries below the collarbones. And this is again the diagram showing the leads has 4 contacts, and this is the programmer, and this is the battery. And this is the post-op CT scan showing us the placement of our electrodes. This slide is just showing the possible complication of DBS. A lot of patients, when they see me, then I will share with them the complication of DBS is quite low. It's about 3 to 5%. Basically, you can divide into a surgical related, hardware related, and also the stimulation related. And during the process of surgery, why it takes about 5 to 10 hours? Because we are very meticulous. We want all these complications. We don't want all these complications from happens. We want to reduce it to the minimums. Yeah. Then I will show one of the patients. This is our very first. This is our patient. This is our first patient who has Parkinson's disease for 15 years before he agreed for the deep brain stimulations. This is videos after the procedures. Maybe I show the. I think I don't have the pre-op one. This is only our I didn't know that. Sorry, I think the pre-op one's video is missing. So anyway, the take-home message is DBS does not cure the Parkinson's disease, but it can improve the symptoms, improve the on time, improve the quality of life. And most of patients, if they achieve the motor improvement, a lot of times they do, their daily activities no longer depends on the others, like the testimonial just shown just now by Mr. Wong. And for this procedure, the patient selections and also the target localizations is very important. We are very strict in the patient's selections. Patient has to be like levodopa responsive, and then they must have adequate motor improvements after taking levodopa, at least 30% improvements. And we will screen the patients before we do the surgery, subject the patient for surgery. We will do refer to the psychiatrist assessment to make sure patient is not having depression or any psychiatric disorder. And we explain to the patients, we discuss with patients, and so that patient can develop a realistic expectation of the motor systems. And the multidisciplinary management is very important to achieve the optimal outcome for the patients. With that, I thank you everyone. Is there any questions? Thien Thien got any questions? Yeah.
Okay, so right, I'll try to answer all the questions that are posted online now. So the first question is how many percent is the improvement with DBS? So generally, if we be pre-DBS, we normally test the patient with what we call as a levodopa challenge test, meaning that the patient comes in early in the morning without any dose of medication since the night before, and we measure a scale called the Unified Parkinson Disease Rating Scale. And we actually let the patient take a slightly higher dose than what he or she used to take, and measure the scale again, the motor scale, the Unified Parkinson Disease Rating Scale. There should be at least 30% of improvement before the patient is actually a suitable candidate for deep brain stimulation. The other way, I guess the question was asking is that after DBS, how much percentage of improvement? So how much percentage, I guess, would depend on what we are looking at, because there are many aspects that we want to improve in DBS. Of course, in general, we can say that at least 30%, but if we're talking about things like tremor, the improvement can be up to 97% improvement in tremors in Parkinson's disease. So the tremor most of the time responds beautifully to DBS. Stiffness and slowness also improve very well, and you can actually lengthen the off time with lower dyskinesia. So I guess percentage alone is quite difficult to express in the sense that there are so many factors that improve with the DBS itself. The second question is that can you describe the type of pain Parkinson patients have? That's a very good question, and I guess to look at pain normally is a non-specific type of generalized pain that they may have, but we are not trying to say that the the Parkinson's pain, how do you know that it's Parkinson pain and not something else? Of course, we normally also investigate or check that it's not something else causing the pain in that area of the body. But generally, how would you know is that one of it is levodopa. If you find that your symptoms, the stiffness, slowness improve and your pain disappears after medications, DBS will also help in that way, where the pain also will resolve after you have done the procedure, just like when you take levodopa and your pain goes away. A lot of times stiffness and slowness, that itself causes the pain. how much is the DBS device? So I guess you're just talking about the device itself. So basically there are two types of battery implants. One is the rechargeable battery and one is the non-rechargeable battery. The difference, of course, is that the rechargeable, you need to charge it every few days. It's quite easy to charge. And the other difference is that the rechargeable battery lasts longer. In general, we say it lasts for at least 15 years, and the non-rechargeable maybe about 3 to 5 years. So it's a longer lasting battery for the rechargeable. The cost of it, we normally don't count the device itself, but the whole procedure. For the rechargeable, it's about 180k all in, and the non-rechargeable is about 150k ringgit. Yeah, I think I've answered the next question, which is how long does the device battery last? So I've answered that question. The next one, Robert's asking, is levodopa the only benchmark medication before being a candidate and suitable for DBS? In general, I would say that we should try a levodopa before going for deep brain stimulation, and I think so far all my patients have been on levodopa before subjecting them for deep brain stimulation surgery. So it's still the standard because it's still the most effective medication. But of course, normally the patients are not just on levodopa. They would be on some other Parkinson medications in addition to levodopa. Roughly how many DBS procedures being performed in Malaysia yearly? I do not have the statistics for the whole Malaysia because I only have those in our center. The university hospitals in Malaysia does that, so I do not know the total in Malaysia, but in our center we did 6 last year itself, 6 procedures. I guess, as you know, the limiting factor is not the candidate or the suitability, but it's more the cost of the procedure and the affordability of the procedure. So that is probably our limit in doing more cases. I mean, just as a comparison, when I was in Cleveland Clinic way back in 2012, 2012, we were doing DBS 3 times a week, 3 days in a week, and 1 day probably two cases. So it's almost like 6 cases in a week. So we cannot compare with those centers that are really just doing subspecialty in that way. Okay, how can the rechargeable battery be recharged? There's a device that you place. You do not have to pierce any of your skin or anything. It's a painless recharging, just like how you would charge your phone nowadays. You don't have to even use the wires anymore. So DBS charging is also very simple. How many brands of DBS device is available? In Malaysia, from what I know until now, we have been using two brands, which is from Medtronics and Sinjut. But so far in our center, we have purely been using Medtronics because of good support from them. There are also others in other countries, such as Boston Scientific, the China types of brands as well, but I do not have experience in all those. Okay, interesting question. How do you guys measure the dopamine level? We don't measure the dopamine levels. I mean, in the brain. Of course, if you are thinking of things like that SPECT scan, that's not available in Malaysia at the moment. So we don't measure the levels, but we examine the patients to look at the symptoms more than measuring levels of dopamine in the brain. So no, we do not measure that. Okay, what's the difference between Parkinson's and Alzheimer's disease? Very common question. The difference, the similarities is that both are neurodegenerative problems. So it's a degenerative problems involving the brain. In Alzheimer's, we are talking more of the thinking, cognition, memory issues, and sometimes some behavioral issues. So patients start getting memory problems, especially short-term memories. Those are dementia, and the commonest form of dementia is Alzheimer's disease. In Parkinson's, we are actually talking more of motor symptoms such as stiffness, slowness, instabilities, and tremor. Any other questions that you all have? Someone, okay, so, Ms. Lee actually asking, someone mentioned that insurance only covers for the surgery and not the device. So that is the reason for the question on the cost of the device. You want to talk about the insurance in?
Yeah, I think for so far, this is quite a new procedures in Malaysia, considered a new procedure, and we have been submitting the application to get the proper codings for and also approval for the insurance cases. So up till now, we still need to negotiate with the respective insurance company, and we will get the necessary approval and agreement before we proceed for the surgery. So far, our patients all using the insurance claim ones has no issue. Insurance are willing to pay the implant and so the surgery, yeah, accordingly.
Right. A very good question from Robert. Question is, does one need to display bilateral motor symptoms before deep brain stimulation? And the answer is no. You do not have to display bilateral symptoms. Although majority of time when you require surgery, you would have bilateral symptoms, and normally one side would be worse than the other. But you can have very bad tremors, resting tremors on one side without tremors on the other side, and almost normal symptoms on the other side, and you could still benefit from DBS. In the past, we used to have two batteries on each side and two wires into each side of the brain. But nowadays, because it's the one battery can support both sides of the brain, we tend to just use one battery alone. Can you find? Can I find you for my DBS collaboration? I normally advise patients to go back to their own center for tuning of or programming of the DBS device, because normally if you have done the surgery in that center, the neurologist or the movement disorder specialist would have done what we call as the monopolar review, which is 1 month, normally about 1 month after the surgery, where they check each context, and it takes the whole day for them to do just that test. So they would know which contact would be the best for you, and which contact causes side effects, and at what voltage the device causes side effects. So I normally do not suggest you to change from one center to another center for programming, but to go back to your center. But unless, of course, is that one person moves to another state far away or another country, and then he or she doesn't have a choice of going back to their center to program, and those are the cases I would do. But if generally you are stationed in Kuala Lumpur and you are doing well, you just had some problems recently, I would suggest go back to your center, because it would be ideal for the same person who did the surgery and the monopolar review to actually program you back. So it's exactly 4 o'clock now, and thank you everyone for attending this live Facebook. And
yeah, thanks everyone. Thanks for the time.